Alrighty, so welcome back everyone. I hope everything is going good. I hope this is ERAS season, so I hope everyone's applications and interviews are going well. Today I would like to do a presentation on transplantation. So I think it's one of the most remarkable achievements in modern medicine, that being transplant surgery. And I want to cover its history, techniques, and essentially the science that allows one life to give hope to another. And that's why I called this presentation Harvesting Hope. So organ transplantation began with bold experiments in the 1900s when doctors attempted skin and kidney transplants between humans. Most of these early efforts failed due to rejection and infection, but in 1954, Dr. Joseph Murray performed the first successful human kidney transplant between identical twins. That's what this top picture is showing. And it's a historical moment that proved that transplantation was possible when genetic compatibility was perfect. As immunosuppressive drugs like azithromycin in the 1960s and later cyclosporine were developed, surgeons could finally start performing these transplants between unrelated individuals. By the 1970s, successful transplants expanded to include the liver, the heart, the pancreas, and the lungs, which essentially transformed the landscape of medicine forever. And here in 1967, they're showing you a picture of the first heart transplant. So next, we need to talk about the type of grafts, because transplantation can involve several types of grafts. An autograft uses tissues from one part of a patient's body to another, like in skin grafting. You get a trauma patient, let's say they're on a motorcycle and they lost a significant portion of skin on their, let's say, lateral leg. You can take skin from other places and then graft it onto that place. That's an autograft. An allograft is between two individuals of the same species, most commonly what we do in transplant service, although research in medicine will and can change. But this is actually the most common form. So allograft, most common form of organ transplant. Xenografts involve transplants between species, often experimental or temporary, such as pig heart valves. Recently ago in the news, they had a guy who had the first essential, I think it was pig heart valves, and he lived, I think he had those for 2 years. They were trying to see if it could be used long term. You can look that up if you'd like to know more. And then finally, there's an isograft or a synergenic graft, and this occurs between genetically identical individuals, and in our case as humans, that means identical twins. So let's talk about what organs you're going to commonly see transplanted. So the kidney is the most commonly transplanted organ, saving patients with end-stage renal disease. Liver transplants, also very common. These treat irreversible liver failure or cirrhosis. And they can also sometimes be the treatment for problems elsewhere that is caused by the liver, such as hepatopulmonary syndrome, HPS, where the definitive treatment and cure is liver transplant. So you can keep that in mind. And then more recently and ever growing is pancreas transplants. This is often done alongside kidney transplants. When I worked with a UCLA transplant surgeon, we mostly did isolated nephrectomies, but then a good amount of kidney plus pancreas transplants as well. And in type 1 diabetes, these can help restore glucose control, and other parts of the body. So we need to talk about the biggest thing. I'm sure many of you know transplant is kind of touted as a rather grueling lifestyle subspecialty, and it usually has to do with the fact of how quickly can they store these organs. So yes, it's very demanding. When I was with the transplant surgeon, if a liver, kidney, especially heart, lungs, if it's ready to be transplanted, you only have so much time to not only do the procurement, but then also get it to the living recipient. So let's talk about some common storage times. So the kidneys can last up to 36 hours, while comparatively the liver is only viable for about 9 to 12 hours. Heart and lungs may be transplanted within 4 to 6 hours, very short time frame, and the pancreas within 12 to 24 hours. However, in 2019, the NIH reported a breakthrough. Scientists extended liver preservation time to 27 hours using supercooling technology and protective additives like, I believe it was trellulose, PG, polyethylene glycol, and glycerol. So this type of innovation, the field of itself of extending organs, or what we kind of call organ in a box, is known as transtonics. And this could dramatically increase the number of viable organs available for transplant. It's a huge area of research, something I would like to maybe dabble in myself. Now, we kind of talked about the brief history. The original barrier was essentially limited to genetic being genetically identical. And that was kind of overcome by drugs. And why it had to be overcome by drugs is because we need to talk about rejection. Sorry, before I get there, here is the NIH in 2019. So, as I said, they use supercooling. Human livers are cooled up to -6 degrees without freezing, a method called supercooling. And then they add additives, which included essentially a modified glucose compound, PEG, trellulose, and glycerol. And here's a picture of it. Obviously, this just looks super cool. And I think this is an amazing field of research. You could help so many people. Transplant as a whole may become more desirable. Although I think people who really want to do it will do it anyways. But back to what I was saying, rejection is a big thing we have to overcome, and we also need to know the type of rejection, and it can have several forms. So a hyperacute rejection happens within minutes when pre-existing antibodies attack the organ. That's your key, pre-existing antibodies. And whether you're watching this for surgical sake, just basic knowledge sake, or for test prep, I would say these types of rejections are probably the highest yield step 2, step 3 portion of transplantation. It's not going to go super detailed surgical. They'll save that for the ab site, but you should know these types of rejection. So hyperacute, within minutes, you'll see this in front of your very own eyes, and that's pre-existent antibodies attacking the organ. Acute rejection occurs within days to weeks. So you can think of it, this one you won't see with your own eyes, and it's the most common form, and this is driven by T-cell mediated immune response. Again, for boards, T-cell mediated immune response, acute. Okay, and I think it's easy to remember hyperacute happens so quickly by thinking about the answer selection pre-existing antibodies. It can happen very quickly because it's already there. Okay, acute takes days to weeks because your immune system has to actually generate a response. And then chronic rejection, this happens over months to years, and this is essentially slowly damaging the organ through fibrosis and scarring. And in some transplants, and this is actually pretty high yield for test, and mainly they'll use bone marrow graft. Graft versus host disease can occur, and this is essentially where the donor, that's the graft, donor's immune cells attack the recipient. So the graft versus host, and the one before the versus is the thing attacking. So it's the donor's graft attacking the immune cells. Okay, and another big thing I'll just add in here to help you with tests and boards. In our surgical program, we get weekly quizzes and didactics, and a very common thing in question stems is with graft versus host is GI symptoms. Generally, when this starts to happen, they start to get diarrhea, stomach ache. I'd say mostly in the cases of diarrhea, and it's obviously that's a very broad symptom and range of diagnoses, but in the context of a patient with a recent bone marrow graft. Okay, So now that we understand rejection, we understand how we can prevent it and essentially the mechanism behind it. These can also be tested. I've seen it. So first off, corticosteroids like prednisone, these act like all steroids and they reduce inflammation and T cell activity. Calcineurin inhibitors, such as cyclosporin and tacrolimus, they block IL-2 production, which can also be sometimes critical for activating T cells. mTOR inhibitors, they're kind of an interesting place of research too right now, such as sirolimus, or even lesser kind of known or used everolimus. I've actually never seen that one used, but it's in the field. They slow growth and proliferation. So they inhibit rapamycin, otherwise known as mTOR, and we know this is kind of a key regulatory kinase that promotes cell cycle progression and proliferation. And then there's anti-proliferative agents. These are things like mycophenolate, mofetil, and azithromycin. And essentially, these prevent lymphocyte replication. So it can inhibit IMPD, inosine monophosphate dehydrogenase, and this is actually crucial for purine synthesis. So they essentially block purine synthesis. And azithromycin is probably the biggest name here. Now, as I mentioned, in your context of testing, step 1, yes, no mechanisms. Step 3, also no mechanisms. Step 2, the way that they're going to test you, and there might even be photos like this on your test or, NBMEs, and you know the side effects. So corticosteroids, they're mainly going to cause weight gain, hypertension, and hyperglycemia. And of course, there's always a subset of people who get kind of mood or mental changes. The calcineurin inhibitors, we split these up because they're both kind of, they may just say they're on a calcineurin inhibitor and ask the most likely drug. We need to know that cyclosporin causes nephrotoxicity, hypertension, hyperkalemia, and gingival hypoplasia. So gingival hypoplasia, I think, is very high yield for cyclosporin. Tacrolimus, obviously associated with nephrotoxicity, neurotoxicity, diabetes, and electrolyte imbalances. I think the important one for this one is diabetes. As a whole, if it's broad, calcineurin inhibitors are nephrotoxic. And then to further distinguish, you're going to look for gingival hyperplasia for cyclosporin, and then diabetes for tacrolimus. All right. And for mTOR inhibitors, sirolimus, the side effects essentially are kind of, how should I say this? They mostly present with delayed wound healing and high cholesterol. So hyperlipidemia, that's kind of the key giveaway for this group. And of course, leukopenia, thrombocytopenia, pneumonitis, these things all have to be kind of worked up and ruled out for they're not caused by other reasons that they probably needed the transplant for in the first place. But I would say mainly focus on the wound healing and high cholesterol or hyperlipidemia, however they word that, or they may just give you the labs. And our anti-proliferative agents, they mainly suppress bone marrow or damage the liver. So as I said, these anti-proliferatives, so if you look at mycophenolate, this causes GI upset and bone marrow suppression. Now, they both, in a sense, cause GI problems because I classify the liver as part of the GI system, but of course we respect it as hepatology alone. Azithromycin is hepatotoxic and also increases infection risk. So they both can probably indirectly cause increased infection risk due to the suppressed bone marrow. And they both essentially attack GI symptoms, but with mycophenolate mofetil, you may be GI upset, which we can say is, diarrhea is how most people say it. We wouldn't probably, I haven't seen or heard of too much constipation, but probably diarrhea. And then we got to watch the liver when people are on azithromycin. So So balancing these medications, one or a combination, is kind of both an art and a science in post-transplant care. Now, how do these end up turning out? Let's talk about success rates. So in kidneys, there's a 95% one-year survival from living donors, and approximately a 90%, some studies say 82, for 5-year survival rate. So kidneys do relatively okay. And it was the first organ to ever be transplanted. So the liver has 86 to 88% 1-year survival. The heart is around 90% 1-year survival. And the lungs are also roughly around 80. So liver and lung, the L's are in the 80s. Kidney transplants are the best, 95, and then somewhere right in the middle is the heart. And an also really cool new area of exploration with a lot of ongoing research is small intestine transplants. They used to be extremely risky, and they've now reached a 70 to 80% 1-year survival. So each statistic represents not just data, but you can think of it as lives renewed through science and, research, compassion, all things that we aim for. So these are my references if you want to look into it more. Basically, from the first failed attempts to the sophisticated operations that you may see today or eventually see, transplantation embodies the power of human innovation and empathy. So I think it's an amazing place for research, whether it's clinical or basic science or even slightly biomedical or on the engineering side, especially with transtonics. And behind every organ, there is a donor's gift, a surgeon's skill, and a patient's second chance. I think transplant's an absolutely amazing field, and I made this presentation for when I was teaching didactics to third-year medical students on their core rotation, and it really helped them with their quizzes. And this is essentially just the story of transplantation, and I really like to think of this as harvesting hope. So thank you guys for watching, and I'll see you in the next one.